Welcome to our comprehensive guide on managing medically compromised patients in oral surgery. Understanding a patient's medical condition is crucial for safe and effective care, both before and after surgery. A thorough medical history provides valuable information about the patient's general health and physical status, helping practitioners make informed decisions. Remember, the golden rule is know your patient well and never treat a stranger. This approach ensures that risks are minimized and outcomes are optimized. In this video, we'll walk through key protocols, classifications, and management strategies for various medical conditions, ensuring you're equipped to handle complex cases with confidence. The American Society of Anesthesiologists (ASA) classification is a cornerstone in assessing surgical risk. Adopted in 1962, it categorizes patients based on their systemic health, ranging from ASA-I, healthy, to ASA-V, moribund. Emergency cases are denoted with an E. This system helps practitioners evaluate whether a patient can safely tolerate a planned procedure. Key factors include the nature, severity, and stability of the medical condition, functional and emotional capacity, and the specifics of the surgery. Thorough risk assessment is essential for successful outcomes in medically compromised patients. Risk assessment is the foundation of safe oral surgery for medically compromised patients. Practitioners must evaluate the nature, severity, and stability of the patient's medical condition, their functional and emotional status, and the type and magnitude of the planned procedure. Factors such as invasiveness, procedure length, blood loss, and vasoconstrictor use all play a role. By systematically assessing these elements, clinicians can determine whether a patient can safely undergo surgery and what modifications may be needed to minimize risk. Stress reduction is vital for medically compromised patients. Effective communication about fears and concerns, scheduling short and morning appointments, and preoperative sedation with short-acting benzodiazepines like triazolam can help. Intraoperative sedation with nitrous oxide and oxygen, profound local anesthesia, and avoiding postural hypotension are key. Maintaining constant verbal contact, limiting epinephrine, and ensuring adequate post-operative pain control further reduce stress and risk. Postoperative follow-up is essential to monitor recovery and address any complications. Preventing hypoglycemia and fatigue is crucial, especially in diabetic and medically compromised patients. Ensure adequate post-operative pain control, monitor blood glucose levels, and provide proper nutrition. Scheduling appointments at optimal times and maintaining regular contact and follow-up help identify early signs of fatigue or hypoglycemia. These steps are vital for safe recovery and minimizing complications. Cardiac patients are at high risk during oral surgery. Categories include congenital heart disease, rheumatic heart disease, ischemic heart disease, and those needing prosthetic valve replacement. Conditions like unstable angina, congestive cardiac failure, septal defects, and recent myocardial infarction significantly increase surgical risk. A history of coronary artery bypass grafting, angioplasty, or valve replacement is important. Surgeons must weigh benefits against risks, especially when choosing anesthesia, and ensure thorough preoperative evaluation. Before surgery, cardiac patients require specific investigations: chest radiograph, electrocardiogram, echocardiogram, stress test, and blood tests, including lipid profile, bleeding time, clotting time, and prothrombin time, INR. These tests help assess cardiac function and coagulation status, especially for patients on long-term anticoagulants. Proper evaluation ensures safe surgical planning and minimizes complications. Patients with rheumatic heart disease or prosthetic valves require antibiotic prophylaxis to prevent infective endocarditis. Surgery should be scheduled immediately after the scheduled dose of Panadura for those on regular injections. Proper antibiotic coverage and medication management are essential to reduce infection risk and ensure safe outcomes. During and after surgery, cardiac patients must be closely monitored using ECG, pulse oximeter, and arterial line. Central venous pressure may be assessed if needed. Intravenous cardiac drugs are maintained until oral feeds resume. Fluid overload should be avoided, especially in congestive cardiac failure. For patients on anticoagulants, minor bleeding is managed locally if INR and PTR are within therapeutic range. If not, intravenous anticoagulants like heparin may be used. Consultation with physicians is vital for dosage adjustments. Patients on anticoagulant or antiplatelet drugs require careful management. Proper history, drug dosage, and current PTR, INR levels must be confirmed. Minor procedures can proceed if PTR and INR are within safe ranges. Otherwise, dosage adjustments or delays may be necessary. Laboratory tests like platelet function analyzer and IV bleeding time help assess bleeding risk. Aspirin may be discontinued for a few days if bleeding time is prolonged. Consultation with physicians is essential for safe surgical planning. Patients with congenital or rheumatic heart disease face risks like infective endarteritis, prolonged bleeding, and thrombocytopenia. Proper antibiotic prophylaxis, hydration, and coagulation tests are essential before surgery. Consultation with physicians is recommended if bleeding times are prolonged. Continued medication for rheumatic fever prevention is important for safe outcomes. Ischemic heart disease and angina require special attention during dental procedures. Stress and anxiety can precipitate anginal attacks or myocardial infarction. If chest pain occurs, stop the procedure, administer nitroglycerin, and monitor vital signs. Avoid vasopressors except limited epinephrine. Stable angina allows routine care. Unstable angina requires emergency-only treatment. Stress reduction, morning appointments, and pre-medication are key management strategies. After an acute myocardial infarction, routine dental care should be postponed for at least 6 months. Consultation with the patient's physician is essential. Morning and short appointments, careful monitoring, and limited use of local anesthetics with epinephrine are recommended. Pre-medication with diazepam can reduce stress. Adjust anticoagulant dosages as needed, and avoid instruments that may interfere with pacemakers. Monitor for signs of fatigue, chest pain, or changes in pulse during procedures. Hypertension increases surgical and anesthetic risks, including excessive bleeding and cardiac complications. Preoperative investigations include chest radiograph, ECG, kidney ultrasound, ophthalmic evaluation, and renal function tests. Blood pressure must be controlled within normal limits before surgery. Continuous monitoring intra- and postoperatively is essential. Antihypertensive medications should be continued, and diuretics may require potassium supplementation. Local anesthetics without adrenaline are preferred for these patients. Blood pressure classifications guide dental management strategies. Normal, pre-hypertension, stage I and II hypertension, and hypertensive crisis each require different approaches. Regular dental care is possible for lower stages, but elevated BP may necessitate stress reduction protocols, physician referral, and postponement of elective procedures. Lifestyle modifications, such as weight control, diet changes, and increased physical activity, are recommended to manage and prevent hypertension. Respiratory diseases, including obstructive and infiltrative conditions, pose significant risks during oral surgery. Thorough history, including smoking and tuberculosis, is essential. Preoperative investigations include chest radiograph, pulmonary function tests, and blood gases. Patients should discontinue smoking, treat infections, and use bronchodilators as needed. During surgery, monitor arterial blood gases, avoid fluid overload, and replace blood loss with packed cells to maintain oxygen capacity. Asthmatic patients require careful assessment of pulmonary function, immune status, and adrenal function. Elective procedures should be performed only when symptoms are well controlled. Risk factors include frequency of attacks, triggers, and medication types. Ensure the patient has taken their medication and has their inhaler available. Anxiety is a known trigger, so stress reduction protocols are vital. Avoid materials and products that may exacerbate asthma, and use antibiotics or corticosteroids as needed for severe cases. Patients with renal diseases face risks related to fluid and electrolyte balance, chronic infection, and hypertension. Preoperative investigations include renal profile, creatinine clearance, serum calcium and phosphorus, urine analysis, and imaging studies. Intra- and postoperative management focuses on monitoring fluid, acid-base, and electrolyte balance. Blood replacement is done with washed packed cells, and potassium overload is avoided. Broad-spectrum antibiotics, such as amoxicillin and doxycycline, are recommended, with dose adjustments based on renal function. Liver diseases, including viral hepatitis and cirrhosis, affect drug metabolism and coagulation. Preoperative investigations include liver enzymes, bilirubin, albumin, and coagulation tests. Avoid anesthetic gases metabolized in the liver. Correct coagulation deficiencies with vitamin K or plasma, and monitor blood volume and cardiac output. Oral manifestations like hemorrhages, jaundice, and gingival bleeding may indicate liver dysfunction. Sterilization and infection control are critical to prevent transmission. Diabetic patients require optimal blood sugar control during and after surgery to prevent hypoglycemia, hyperglycemia, and ketoacidosis. Preoperative investigations include blood sugar, glucose tolerance, renal profile, and urine analysis. Patients on oral hypoglycemics are shifted to insulin on the day of surgery. Intra- and postoperative monitoring of blood and urine sugar levels is essential. Signs of hypoglycemia and ketoacidosis must be recognized and treated promptly. Broad-spectrum antibiotics are used to prevent infections. Thyroid disorders are classified as hypothyroid, euthyroid, and hyperthyroid. Euthyroid patients pose no surgical risk, but elective surgery should be postponed for hypo or hyperthyroid patients until euthyroid status is achieved. Preoperative investigations include thyroid hormone levels, serum electrolytes, and proteins. Monitor vital signs and hormone levels intra- and postoperatively. Avoid epinephrine in uncontrolled hypothyroidism. Minimize stress and adjust medications as needed. Oral manifestations and systemic complications must be considered in treatment planning. Adrenal disorders, including Cushing's syndrome and Addison's disease, require careful management during surgery. Symptoms include diabetes, hypertension, and poor wound healing. Preoperative investigations focus on renal profile, electrolytes, blood sugar, platelet count, and coagulation profile. Patients with adrenal insufficiency need corticosteroid supplementation to prevent adrenal crisis. Intra- and postoperative management includes monitoring vital signs, fluid and electrolyte balance, and blood sugar levels. Guidelines for glucocorticoid dosing depend on surgical stress level. Neurological disorders, including cerebrovascular and seizure disorders, require maintaining adequate cerebral perfusion and controlling seizures. Preoperative investigations include skull radiographs, CT, MRI, EEG, and liver function tests. For epileptic patients, anticonvulsants should be continued up to surgery. Intra- and postoperative management involves intravenous anticonvulsants, avoiding hypotension and hypoxia, and maintaining cerebral perfusion. Delayed surgical fixation may be considered for high-risk cases. Hemopoietic disorders include anemias, leukocyte disorders, and coagulation factor abnormalities. These conditions predispose patients to prolonged bleeding and infection. Preoperative investigations include complete blood count, bleeding and clotting times, prothrombin time, partial thromboplastin time, and factor assays. Build up blood counts before surgery, and for hemophiliacs, raise factor VIII levels to 50-70%. Intra- and postoperative management focuses on avoiding trauma, achieving hemostasis, and monitoring blood counts. Broad-spectrum antibiotics are used to prevent infection. Immunocompromised patients, including those with autoimmune disorders, are highly susceptible to infections. Preoperative investigations include blood count, liver and renal function, serum proteins, blood sugar, and chest radiograph. Broad-spectrum antibiotics are essential. Management varies by condition, but supportive care is often the mainstay. Special precautions are needed for HIV-infected patients to prevent transmission. Autoimmune disorders may contraindicate elective surgery and require operation during remission phases. HIV-positive patients require careful management to prevent transmission and address oral manifestations. Early diagnosis and counseling are critical. Laboratory tests include ELISA, rapid tests, and Western blot. CD4 count and viral load guide dental treatment decisions. Asymptomatic patients with CD4 is greater than 500 can undergo routine procedures. Symptomatic patients with CD4 is less than 200 require emergency-only surgery with antibiotic prophylaxis. Infection control, pain management, and regular monitoring are essential. Healthcare workers must be prepared for accidental exposure to HIV. Immediate steps include washing injuries, flushing splashes, and irrigating eyes. Report exposure and start post-exposure prophylaxis within 2 hours. Basic regimen includes zidovudine and lamivudine. Expanded regimen adds indinavir. Testing is done at exposure 6 weeks and 12 weeks. Proper handling of sharps, specimens, and instruments is essential to minimize risk. Dental treatment for HIV-positive patients focuses on CD4 count and viral load. Asymptomatic patients can undergo routine procedures. Symptomatic patients require emergency-only care with antibiotic prophylaxis. Regular monitoring, infection control, and pain management are vital. Special protocols for theatre, personnel, spillage, instruments, and sharps ensure safety for both patients and healthcare providers. Proper sterilization and labeling of specimens are mandatory. Radiation therapy involving the oral cavity and salivary glands can cause mucositis, loss of taste, xerostomia, infections, radiation caries, osteoradionecrosis, and trismus. Preventive dental care, oral hygiene, and restorative procedures are essential before, during, and after radiotherapy. Daily topical fluoride applications, jaw exercises, and careful management of dentures help reduce complications. Extraction trauma should be minimized, and antibiotics given as needed.